take the roll for us?
Yep. Maria Bonneville,
Present.
Monica Carson,
Here.
Mark Fischel-Colbury,
Here.
Elena Flowers,
Present.
Judy Gasson,
Here.
Larry Goldstein, David Higgins, Vitam Basiani,
Yeah.
Pat Levitt, Shlomo Melmed,
Here.
Chris Miaskowski, Carol Watson, Keith Yamamoto. Back to you, Mark.
Great. And if you could let me know, do we currently have a quorum or I think we're anticipating more to come in, but how is our status currently?
We are too short of quorum. We're expecting a couple more to join a little later.
Okay. Well, in that context then, because I think there's a ton of material that we need to get through, I'd like to go ahead and get started. So, from that perspective, the first item on the agenda is consideration of the CIRM interim research budget for the fiscal year 2024-2025. And with that, I'll turn it over to the CIRM team to launch that agenda item.
Fisher-Colbury. This is Jennifer Lewis. I'm the Vice President of Operations at CIRM, and it's my pleasure today to share with the subcommittee the fiscal year 24-25 research budget. So as you all know, we start with all our presentations with our mission statement: to accelerate world-class science to deliver transformative regenerative medicine treatments in an equitable manner to a diverse California and world. So before I kick off with the agenda for today, I wanted to share two informational slides with the subcommittee. This gives you context of our grant funds as a whole, as well as it relates to Prop 14. This slide displays grant funds available for both Prop 71 and 14, and the total is $7.64 billion in grant funds as of April 30th, 2024. The breakdown of this as of April 2024 of what has been encumbered and unencumbered is shown here. So to date, $3.78 billion has been encumbered, which means these are actual funds that have been paid out by CIRM or have been committed in the form of a grant contract that has been approved by this board. The unencumbered grant funds totals $3.86 billion. And I would note, as many of this committee knows, as you've had discussions about strategic allocation framework, this number varies slightly to what has been presented over the past few months for two reasons. As the number that my colleague, Dr. Canet Aviles, has been sharing was a projection. Well, this is actual numbers. So this is the total as of today of unencumbered $3.86 billion. So we're roughly halfway through the research funds. This next slide is another visual that is focusing on Prop 14 funds. So these are the research funds and allocations determined by the proposition. This first column is research for research therapy development and therapy delivery. This is what's specified in the proposition of $3.4 billion. And as you can see, as of today, we have $764 million committed. And this arrow on the side, what that's showing is just the proposition does call out two areas that are earmarked as up to amounts for building and equipping shared resource labs, which totals $26 million, and then building, equip, and operating community care centers of excellence, which totals $78 million. The middle column is showing diseases of the brain and central nervous system. Prop 14 calls out $1.38 billion towards this type of program and grants. $243 million has been committed to date. And the last bucket is access and affordability, which $96 million is allocated in the Prop 14, of which about $2.4 billion has been approved by the board to date. So in the next few slides, what I'll be going over today is the fiscal year 23-24 approved research budget results, and then go into the fiscal year 24-25 proposed interim research budget, the major drivers, and any considerations. So let me walk you through the approved research budget and the actual results. As you can see here, the first column displays the fiscal year 23-24 approved research budget, which totaled $519 million. The second column is displaying the commitments to date. which totaled $297 million. Since this presentation was prepared as of April 2024, we have many still pending reviews and activities for the next 2 months. So the third column is displaying any pending commitments that are coming to an ARS meeting this month or by June. This includes for clinical, 11.9 million that will be coming next week to the May application review subcommittee meeting, 441 million for the translational program that will also be coming to the May application review subcommittee meeting. No pending discovery applications, 250,000 in education conference grants that are pending approval by the end of the fiscal year, and then no pending infrastructure approvals by the end of the fiscal year. So this is a total of 53 million in pending commit activities that will go to be presented for approval before the end of the fiscal year. So the fourth column is what we call estimated to finish, meaning that it totals the previous 2 columns. And that total is 351 million is where we expect to land at the end of the fiscal year. The one caveat I will say is that for clinical, we still have one pending GWG that is occurring this week, where we anticipate that the applications that have been submitted could likely deplete the remaining funds in the clinical budget. So the last column is what we like to show is the variance. Then this is the variance between the 23-24 approved budget and the estimated to finish. And I'd like to go line by line on this because there's some explanations that I think will be useful for this subcommittee, and as well as it relates to the 24-25 budget. So the first is there's 41 million remaining in the clinical variance between the approved budget and the estimated to finish. This may be depleted further as there is one pending GWG and application review subcommittee that would come in June with the totals still unknown. The next is 1 million remaining variance between the translation approved budget and estimated to finish. 93 million variance between the approved budget and estimated to finish for discovery. And the reason for this large variance is due to two programs. The Quest DISC-2 program and the Remind-L programs were postponed during the fiscal year due to various operational reasons, extending an application date or just adjusting the review schedule based on some of the flow control considerations of the organization. Therefore, although we're accepting applications or they're pending review, the actual approval for those 2 programs will not occur until 24-25. And therefore, we have a larger variance in that program in Pillar. For education, there is a variance of $914,000. And then for infrastructure, there is a $30 million variance from the approved budget to estimated to finish. This is also due to an operational change, but the shared research lab program. As you may recall, that program had applications come to the board in March for approval. And in that approval of the Tier 1 applications, there were several Tier 2 applications that were recommended to go back to the respective GWG or facilities working group to be re-reviewed and considered. And so those applications are being re-reviewed, but the actual approvals for those Tier 2 applications will not occur until the 24-25 fiscal year. So the total variance at the end of 23-24 that we're anticipating is 168 million. This next slide was at the request of Dr. Goldstein. As we reviewed the budgets, it's showing the historical research budget performance. And he felt it was important, and the CIRM team agreed that to show now that we're several years into Prop 14 and we're reaching our operational height of demand and reviews, to also show our performance of what the ICOC approved as our total budgets each year and what was actually committed and uncommitted at the end of each year. And so all this graph is showing is the 4 years that we've had in Prop 14. You'll notice the first year is 6 months, which was due to a ramp up of the organization. But you'll see that the first column, the first number in that column, 352 million, is showing the total approved budget, then the committed funds and uncommitted underneath that. And that's informational purposes for this committee as we consider future research budget approvals and forecasting. So before I go further, I'll pause if there's any questions on the historical. If not, I'll keep going to the 24-25 budget. Okay. Now I'll dig into the 24-25 interim budget. And as mentioned, this is a 6-month interim budget that supports application review subcommittee approvals from July through December of 2024. And the rationale behind this was that the CIRM team, as we're going under strategic allocation evaluation and coming to the board in September with recommendations, then following that, this team would come in December with any revisions that needed to be made to the research budget for the next 6 months. So this budget that I'll present to you shortly is only supporting activities over the next 6 months, which include monthly clinical approvals, such as the Tier 2 resubmissions that we've been taking in over the past several months, as well as aligns with my colleague, Dr. Sobrano's review process changes that he'll be presenting shortly for the clinical program and reopening that program. It also includes approvals for translation round, quest round, the Remind L round that I mentioned, community care centers, and Tier 2 application reviews for shared research labs. So to give you a little bit more detail into how we determine the allocations for each of the programmatic budgets, the clinical budget, we are requesting 145.5 million. This is based on the number of awards determined by the goals of the therapeutic development team for fiscal year 2024, and we're taking that account for the 6-month period. When we calculated this number, we did this by the maximum total award amount for the various programs in CLIN 1, CLIN 2, and the new CLIN 4 opportunity. For the translational budget, we are requesting $60 million. This is based on the average number of awards in fiscal year 23-24, as well as the average award amount during the past fiscal year. For the discovery budget, we're requesting 116.2 million. This is the request for the 2 programs that I mentioned previously, the Quest program for 28 million and Remind L of 88.2 million. For the 2 programs that we have opened up applications for and are in various stages of the process, but will not have approvals until the 24-25 fiscal year. For education, we are not requesting a budget for the 6-month period. The rationale for this is there are 2 mechanisms for our education conference grant program. So EDUC1 is our conference grant program. One mechanism is what we call unsolicited proposals, where we offer about $50,000 per award to various conferences that are related to the regenerative medicine area. Due to the strategic allocation framework, the CIRM team is recommending that we do not offer this program for these 6 months, as we really want to, once we have those recommendations, align that program announcement to really call for those things that align with our strategy and the goals that this subcommittee and the board approve. Additionally, we have another mechanism that's more of a CIRM-driven specific, such as education or conference and things of that nature. And we don't anticipate any RFAs during that period. So again, supporting the not requesting for any budget for that category for this 6-month period. And then lastly, this infrastructure budget, we're requesting 88.8 million. This is for the shared research lab Tier 2 applications that I mentioned of 28.6 million. And then in addition, we are accepting applications right now for the Community Care Centers of Excellence program, which is a total of $60 million. So what this slide is showing is a side-by-side of the fiscal year 23-24 approved budget and the estimated to finish. And then the proposed fiscal year 24-25 budget from July through December, which totals $410.5 million. The last column, the fourth column, is showing what essentially is a reallocation from fiscal year 23-24. These are the 3 programs I identified, which were 2 in discovery and as well as 1 in the infrastructure shared labs that due to, to review schedules and just operations, we won't have actual approvals until 24-25. And then lastly, so the request today is to recommend, for this subcommittee, is to recommend approval of the fiscal year 24-25 research budget to the ICOC. And I can entertain any questions, and I'll hand it over to you, Chair.
Thanks for the great discussion. Are there questions about what's anticipated here with respect to the 6 months sequencing and with respect to any questions of the presentation? Any other comments from CIRM staff related to what's under review here? Okay, hearing none. Now, I think we need to proceed to a vote, if I'm not mistaken. If that's the case, do we currently have a quorum?
Yeah, Mark, we're just one shy of a quorum. Fortunately, we
Okay.
have an option available, which is we can pass along to the board in June what a sense of the subcommittee members are that are here. So
Okay.
what we would normally do at this point is you might ask if there's any objection, to forwarding this proposed budget to the board, and we'll listen to see if there are any questions or concerns that members have.
Thank you for that clarification, Scott. And with that in mind, are there any objection or considerations related to giving a sense to the board of what the Science Subcommittee would like to do with respect to the discussion on the 6-month budget? I'm not seeing any flags or hands up. Scott, if we need to do any public comment at this point or not?
It's fine to invite public comment to this agenda item, since we'll be closing out this agenda item and getting ready to move on to the next. So it is appropriate to invite public comment, if any.
Okay, great. Then with that in mind, are there any questions or comments from the public?
There are no hands raised.
Hands raised. Okay, well, I guess in summary then, without requiring a formal vote, the sense of the Science Committee is to go forth with the recommendations from the CIRM team related to the interim research budget and present that to the board. So thank you.
Thank you.
Great. So I think that closes out that agenda item. We can move on to the next agenda item, which Dr. Sobrano will be presenting for our review and consideration. And I'll turn it over to Gil.
Okay, thank you very much, Mark. Let me just share slides. Okay, so thank you all for coming to this meeting and for your attention today. I want to present to you where we are in the flow control development process and what ideas we have that we want to bring to the board ultimately in June. I want to start off with just a timeline that you have seen at other Science Subcommittee meetings that Rosa has presented, which are related to the strategic allocation framework. But within it, there is the flow control, which we are doing concurrently. And just so that you get a sense of the timing of what we're proposing to do, and assuming that everything moves as we expect, The hope is to present our evaluation and assessment of where we are on the flow control, along with a proposal that I'm sharing with you now, and potentially resume clinical application submissions, with the first deadline being at the end of July. If we do that, I extend the timeline here in this next slide into the latter part of the year. So if the July deadline is the first one, then the earliest clinical application approval would begin in November of this year, in order to account for the review cycle to complete. And I will go into detail of what we're proposing to do, but assuming that that works, that's when the earliest date would come. As you know, we are also working on developing what may be a new set of priorities and thinking strategically as well. And so recommendations related to the strategic allocation framework will come to the board in September. So from that may emanate with those recommendations, new concepts, new ideas that would lead to new opportunities, including changing the clinical program. Whatever those changes may be, would begin in January of next year, the next calendar year, 2025. And so the earliest approval of any CLIN applications that are responding to those new opportunities would happen in May of next year. So we're looking at a year ahead. And that's just something to keep in the back of your mind in terms of the timing of what we're talking about now. The other thing I wanted to stress is that these two efforts, the clinical flow control process that I'm going to focus in on today, and the strategic allocation framework, are two parallel efforts. They are certainly, we are coordinating to keep them aligned, but they are and have separate goals. The focus of the strategic allocation framework is strategic, while the clinical flow control process is really focused on responding to the increasing numbers of applications that we have observed in the clinical program. And it's not meant to address any funding strategies. It is also intended to address the challenges based on what the existing clinical program eligibility and structure is, meaning we're not necessarily working with something that we don't know what the priorities will be, say, come September. However, we do want to keep an eye towards what we're working on, and so therefore whatever we come up with in terms of a new process, we want it to be adaptable, and we want it to be applicable even beyond what we present as far as strategic allocation framework after September, because we don't want to have to stop again in order to rebuild something else and create more delays. So the idea is that it would be flexible. The other thing I want to highlight, and this is now getting into the creation of the process itself, is a little bit of the historical background on how the current clinical process came to be and the context under which it was created. So this was in 2014 when we launched CIRM 2.0. It is when we launched the clinical TRAN and discovery programs as pillars that we would be specifically funding on a continuous basis. Before 2014, we had supported up to, I think it was 16 clinical trials that we had at the time. And those came about through ad hoc reviews that were set up. They were not very predictable. They were kind of as best we could, maybe once a year. And at the time, the field of regenerative medicine had not yet advanced many candidates to the clinical trial stage. So the philosophy behind our program was really to fund any meritorious project that ultimately reached this stage. Because if we had a cell therapy that had reached that stage, why wouldn't we fund it? And as such, when we considered the projects, we were assessing them independently of each other, because each cycle was looking at one or two proposals. So in the case where you have just one proposal, there was nothing to compare it to, and so ranking proposals didn't make sense. And so that's where we started, and we started evolving and creating the process around that. And over time, it became a pretty robust process that I will give you a little more detail on. I want to just show you a couple of elements that I think are important to know about the existing process. It has been aligned over the years with the target number of awards that we have for CLIN 2, those are the clinical trial level awards, and the CLIN 1s, which are the IND enabling. And given the success rate that we have observed over the years, the number of applications that we need to review is shown in that fourth column of, for CLIN 2, 28 to 32 applications in order to get you 16 awards in a given year. We hold 11 cycles per year. And so what you need is about 3 applications to come in for each cycle in order to achieve that goal. For CLIN 1, it's similar with about 2 new applications coming in each cycle. And so it's clear from that at least what we're targeting and the general number of awards that we expect to give out aligns well with the process. But as we have seen more recently, the process fails when you get many more applications because we can't support. It doesn't scale up higher than having 5 or so new applications per cycle. But the existing process is quite a rigorous one. Some folks have pointed out the high success rate, but I want to explain that high success rate as being one that is the result of several elements. Most applicants go through one application revision and sometimes more before they get a recommendation to fund, meaning that the grants working group looks at their application a lot of times 2 or more times. With few applications per cycle, we have the full participation of the grants working group panel that meaningfully contributes to each of the evaluations. We have 15 scientists that our panels are limited to. But with having 1 to 5 applications, all of the panelists can look at all of the applications and contribute to the discussion, as often happens. Once you start having more applications than that, then the reviewers start focusing simply on those that they are assigned to. Most of the successful applicants that we have receive significant guidance from our therapeutics development team. So they provide advice on what makes a competitive application and what elements should be included within their application for them to be successful. And so certainly those things contribute to a high success rate, as well as also the fact that each of the panels are tailored to the needs of each review cycle. So depending on what group of applications we get in a given cycle, we're going to tailor the grants working group members based on the expertise requirements that are needed to cover those applications. So there's a lot of elements from this process as it has been built out that we would like to keep in considering how we scale it up or how we account for now an increased number of applications. We want to continue to have the maximum contribution from the full grants working group panel on each application to the extent possible. We want to continue to have a tier 2 process that allows projects to improve because they do. They respond positively to the comments that they get from the grants working group. But it also has the effect of preventing appeals, meaning the applicants don't feel that they don't have that opportunity to respond to comments. And ultimately, when an applicant appeals, they simply want the review panel to look again, and they typically will get that opportunity with a tier 2 score. We want these to continue to be frequent and predictable and quick to the extent that we can, in order to allow applications to come in when they're ready. And that's important because in the past we had applications that would, when we had a review, say once a year or on an ad hoc basis, applications would come in that didn't really have a complete data set, really didn't have all the elements that would be required to have a competitive application, because they were really too early, but they felt compelled to submit because otherwise they'd miss their opportunity. Similarly, we had applications who were sitting for a few months waiting for a deadline to come up before they could submit, even though they were more than ready. So having that frequency and the predictability of it certainly helps us capture projects when they are ready and avoids unnecessary delays. We want to continue to offer opportunities for clarification. There's different ways in which we do that. That allows the reviewers and the applicants it allows the reviewers to better understand what the applicants intend by having them ask questions of the applicants through our staff. I think that helps in the overall review process. We want to continue having the participation of the grants working group patient advocates participating in the evaluation of the projects, particularly the DEI elements. Having them be a part of the group is something that we all agree is quite essential to the review. The scientific members view it as a valuable contribution to the reviews, and we feel that it provides our patient advocate board members a very meaningful way of participating in these reviews. We want the alignment in terms of the targeted number of proposals that we want to funding to align with the process itself. And we want to maintain the overall rigor that we've been trying to uphold over the last several years that this clinical program has existed. So with that in mind, we looked at a couple of different overall approaches. One was to create a preliminary filtering or qualifying process that feeds into what is largely the existing clinical review process. So a way of determining what ultimately comes in and having some kind of selection that happens beforehand. The other option was to just completely rethink this, to toss that away and think of a new clinical program or adopt what we do for discovery and translational applications, where we certainly receive a lot more applications. Doing so, however, would risk having a greater number of applications that need to be reviewed in a cycle, and the level of rigor and attention that we can dedicate to them would inevitably have to decrease. The frequency would also need to be less in order to accommodate the changes, and we think those would require more extensive policy changes and changes to the applications and program. So we went with really trying to create a filtering or qualifying process as the approach we would try to see how that would work. This is an illustration of the current clinical application and review process, which we divide into 3 phases that begin with the application submission. We assess applications for eligibility. Those that are accepted go into the merit review by the grants working group, and then those recommendations from the grants working group go to the board. And overall, assuming an application is successful in getting a positive recommendation, the cycle is about 3 months. What we are proposing now is to create a process that adds a competitive qualification step at the onset. So applications are submitted, and at this step, they go through a rank scoring based on specific criteria that I'll describe in just a second. And we select the top 5 applications that then advance into the non-rank scoring that we already have in the existing process. Now that would add about a month to the cycle, so we are now having overlapping 4-month cycles instead of 3-month cycles. Okay, so let me go into a little more detail on what that qualification process would look like. This would apply only to the CLIN 1s, that's the IND enabling, and the CLIN 2s, the clinical trial proposals, but not CLIN 4. The CLIN 4 are the new BLA stage projects. The CLIN 4 already goes through a process that is equivalent to that almost, because they have to have a CLIN 2 in order to qualify for a CLIN 4. And before anybody submits an application for CLIN 4, they have to go through conversations with the therapeutics development team to ensure that they are ready. We're not expecting to get more than 2 or 3 in a year for CLIN 4, so we're not talking about large numbers there. For this process, we're creating a qualifying score that is based on several objective criteria as well as some subjective, and I will give you some examples and some specifics on that in a second. Based on those criteria and how they score, we would rank the submission and, as mentioned, advance the top 5 into that cycle. But we would retain the submissions in that competitive pool for a couple of cycles, meaning that any given application has multiple opportunities to advance into the review cycle. Now, if a pool has 5 applications or less, well, then all of them would advance, and there would be no need to qualify. If we now go further in assessing what the qualification process looks like, we would start with a step 1 in which we would assess applications based on objective criteria that are scored by the CIRM team. And so we would assign points for each criterion met. The applications would be ranked, top 5 would qualify for review. However, there is the likelihood that there are going to be instances where we have ties and where we can't select what the top 5 would be through the objective criteria alone. If that is the case, then we move to step 2, which would involve subjective criteria that are scored by grants working group members. And so we would recruit grants working group members to help us score applications based on 4 to 5 key elements, and I'll give you some examples of those. But the idea is to keep it high level and short. We don't want them to go into an extensive review. We want them to help us highlight which ones they feel are of potential value and worth digging into more. The applications would then be ranked by their score, and then of course we would break the scores would break those ties. An application that does not qualify can either be withdrawn by the applicant or it can be re-ranked for up to 2 additional cycles, as I mentioned before. But after that, they come out of consideration and they can't be resubmitted for 6 months. And that is necessary in order to avoid just having applications constantly in the competitive pool without at least making some significant change. So here is some examples of the objective criteria, and I'll go into a little more detail. So examples of objective criteria that would be scored by CIRM are, for example, if this is a California organization or not. We would, for example, favor organizations that are California-based. The percent expenditures in California is another example, whether it's a pipeline project, meaning it represents a progression event, something that's advancing from a CIRM-funded TRAN program into a CLIN 1 or a CLIN 1 into a CLIN 2 and so on. Based on the therapeutic type, for example, we would advance cell therapies over small molecule approaches, given our mandate as a stem cell agency. Some examples of subjective criteria that would be scored by the grants working group expert are related to the overall value proposition of the project. These that I list here are part of the review criteria that they already utilize, but these are the high level ones that would allow them to distinguish among projects more quickly than digging into the application to assess things such as feasibility and so on. Here we would ask them, is this something that addresses an unmet need? How well they think it impacts on patients if the approach is successful? What kind of improvement over standard of care they would expect to see, and perhaps whether they have a sound rationale. And again, the subjective criteria would be applied only if the objective criteria don't allow us to discern between the applications. So in thinking of the process this way, and I do want to just reiterate that we are presenting this with the idea of getting input and feedback from you, particularly if you have ideas for other criteria that we could use. None of these are set in stone or finalized in any way. Our goal was to bring them to you with the idea that we would get some feedback and perhaps additional ideas. So the way we thought of these criteria, we want to choose things that are generally supported by Prop 14 or the clinical program concept or announcement. They obviously do have programmatic value, and so that's why we need your okay to move forward with what we choose, and likely would include in the concept. But the idea is, if we're comparing otherwise eligible applications, what should we advantage? We would recommend supporting things such as California-based organizations over non-California, cell therapies and gene therapies, since that has been largely our focus, over other approaches such as small molecules. We would also suggest advantaging project advancements, those that have received previous fundings and are advancing to a more advanced stage of development over new projects. Advancing trials that are at a greater later stage, so a pivotal phase 3 over a phase 1 or over a CLIN 1. And perhaps projects that are less likely to receive funding from other sources. Now, in thinking about these criteria, the idea is, to the extent possible, in order to make them as objective as possible, is that these are criteria that are not unlikely to change over time, that these are just intrinsic to the proposal, to the applicants in some way, in order to allow us to really discern those that we want to move forward. So that's the proposal for the qualifying process. I want to just very briefly move into some other changes that we want to make that we think are important to streamline the process. And this is related to the changes in the non-rank process. We want to limit the tier 2 resubmissions that we currently have to one time. We have had more recently resubmissions that happen several times, but we don't know that it offers any more of an opportunity for improving the application. So the idea would be to limit them to one opportunity to make the changes and fixes. And so resubmissions would be scored a 1 or a 3 thereafter. The second thing that we think would be important to do is to tighten our internal deadlines for resolving eligibility issues and other related elements that come up. We do a lot of work to work with applicants and sometimes have extensive back and forth to get their eligibility elements straightened out. But we want to just, at this point, out of efficiency, in order to be able to move more quickly, have a single eligibility notice, a chance to resolve. And if they can't resolve it, they move out of the cycle so that we can move on with those that are going to be eligible and able to move forward into the review. This slide is just highlighting some of the things that we have to change in terms of our policies or regulations in order to move forward with this process. The most obvious one is the Grants Working Group bylaws, which describes in a lot of detail the scoring as well as the tier 1, 2, and 3 process for clinical reviews as well as other reviews. But in order to restrict the tier 2 process in the clinical reviews to one instance, we need to change some language in the bylaws, and I think that was included in the materials that were provided to you, so you can look at that. It's just a very I think it's just one sentence that needs to be added. We also expect that we would update the concept and the program announcement in order to define the qualification step itself and the specific selection criteria that are used. We want the selection criteria to be transparent to everyone, including the applicant, so that they understand that we're using it in order to advantage some applications over others. It doesn't prevent them from being reviewed because it's not eligibility, meaning each of the qualification criteria alone are not enough to prevent somebody from moving forward. It is really the combination of factors that contribute to a score based on these criteria. And to the extent possible, we want to create clearer eligibility criteria if we need to, or refine our review criteria. I believe, yeah, that's the end of the slide deck. And again, just want to invite your feedback on this overall process. And Mark, I'll turn it back to you for any discussion and questions.
Thanks, Gail, for an excellent presentation. And before we launch into questions, I just want to compliment the CIRM staff for a great process to date in terms of the effort and the quality of what's been done on the GWDG process for all this activity currently, with the acknowledgement that the tidal wave of new applications is one of the determinants for requiring a change here in order to keep up our quality level and support. But the CIRM team's been outstanding at progressing with a very strong effort. So thank you for your efforts there. With that in mind, though, I would like to see if there are any questions out there. I'm scanning through the list here. I've not seen anything, but does anybody have questions about what's being considered here? I guess Terry Jones. I'm not sure who was first, Terry or Vito. I'll go to Terry.
Vito first. We're not ready for a public
Vito.
comment, Terry.
Okay,
Oh, sorry, my mistake. Thank you, Vito. Our chairman. You're on mute.
Thank you. Sorry. Yeah, thanks, Mark. Gil, compliments on the lucidity of the presentation. It's not really a question, but I'm anticipating maybe a more general reaction from the board. And if you wanted to pull up the slide, it's the one that talks about the objective and the subjective criteria. I have no problems at all with any of the criteria. I agree that the objective ones are intrinsic and sort of they're immutable. They jump out of the page. And the same thing with the subjective ones. But what I would ask you to do for me, could you rehearse the discussion that must have happened among the team as to why the subjective criteria were relegated to a tie-breaking location in this process? You could make an argument that some of the subjective criteria were themselves programmatic: unmet medical need, exceeding standard of care, and so on. So was there any discussion to incorporating some of the subjective criteria in the initial screening criteria before the consideration of any tie or tie breaking?
Yes, and so thanks for the question. I think part of it was thinking about how to streamline this to the extent possible, and thinking about what we would need to do. So let's say we were looking at 10 or 20 applications that would then need to be screened by grants working group members with these subjective criteria, along with then the CIRM team looking at the objective criteria. We felt that it would be easier if we focused the grants working group effort, because recruiting the right number of individuals and narrowing the number of applications that would require the tie breaking element would be fewer if we did the steps sequentially rather than at the same time. And would only be necessary if in fact we ended up with a tie. So it was really about thinking about efficiency in the process as to why we made it a sequential two-step.
Mm-hmm. Mm-hmm. Good, thank you.
Keith.
Just following Vito, I had the same kind of concern, and my feeling, Gil, so thanks for this. It's a terrific presentation, and you clearly have thought through it very carefully, so thank you for all of that. I had a similar response as Vito's. It seemed to me that that getting the GWG to weigh in on these and maybe other subjective criteria that I can think of would not actually be inefficient. You know, having served on many review panels over the years, I can say that it really is very simple to make this assessment for criteria such as this, or in fact, in kind of scanning the specific, I don't know how the applications are structured, but in NIH grants, scanning the abstract and specific aims, and it's quite simple to reach the conclusion that this is something that should go forward to full review, that is sufficiently meritorious on its face to be able to do that. And so in the NIH process, where you're faced with a long grant application, it's always been a bit of a source of frustration to me that you have to go through the whole process of review, having looked at the aims, maybe a bit about the methods, but more the aims, the value of the question, the value of an answer if the project is completed. That assessment can really be made in a few minutes. And so it's frustrating to have to go through and prepare a full review when you really know what the fate of this is going to be, at least in your hands as a reviewer. I think it wouldn't be hard it's not a tough task. And what we had discussed earlier when we were informally discussing is really moving toward the NIH process of triaging about half of the applications is what the NIH uses, but you can pick a different level based on the ways that the applications seem to be coming in, the quality of the applications that are coming in, and so I regard the subjective criteria as fine, but in fact, I believe that it wouldn't be a tall task to ask the GWG to look at the substance of the proposal itself and make a judgment about whether this should or shouldn't move forward, applying a triage type of process that would shorten the list of proposals to be examined. And I guess maybe the preliminary question I should have asked is you know, is the experience that scoring the CIRM staff's work of scoring these objective criteria will be sufficient in general to be able to sort out and identify the top 5, you know, with or without ties? I mean, is there going to be a big range of people that are sticking with these objective criteria or not, that allow you to do this separation? So is it, you know, do you expect that really only a few would advance based on ties? Only a few would advance to being scrutinized by the grants working group, or is this sort of a, you know, it's the expectation that most of them would do well of these objective criteria, and you'd end up with lots of ties, essentially meaning that most of the list would go to the grants working group. So I guess it's really 2 questions. That maybe is the first one, and the second is, you know, or comment that it's my view from personal experience that being able to ask the grants working group to make these assessments that would end up ranking the applications sufficiently to cut down the number that have to be examined for full review would be straightforward, and in fact would yield examination of the best applications in a given round.
Thank you, Keith. We did a sort of a mock trial, if you will, of the qualification process with the objective criteria based on several of the recent cycles that we've had to see how the applications were. And in general, using criteria like we've selected for the objective criteria, in most cases allow us to pick the top 5, but you do end up in some cases with ties that need to be addressed. So it's not, you know, something where, you know, you might as well give it to the grants working group because you're going to need to do it anyway. It kind of does depend on the cohort of applications, but in most cases, the objective criteria alone can help you identify the top 5. I agree with you that the assessment by grants working group members, you know, to very quickly let us know, you know, this is something that is worth looking at further or not, it is something that can be very simple. What I think we were challenged by is more who those experts should be that are going to assess whether there is an unmet need, whether this truly represents something that's an improvement over a standard of care for each of the applications. We really do need an expert in that arena, in that area, who is likely a clinician, to be able to make that assessment. So that means, from our perspective, we need to make sure that for every large group of applications that we identify the right reviewers who can make that assessment and give us back a score. And so that's where it becomes more difficult, particularly if we have a lot of applications that cut across many different disease indications and many different approaches. We thought of different potential ways of doing that, to have a set of what we would call generalist grants working group members who have broad views of things and can give us those opinions, or in cases where we can, to have experts that are well versed in the disease to be able to give us the opinion. So I think in the end, we thought if we're limiting this to only a select number, those where we end up having a tie, it allows us to actually recruit and identify those that have the most expertise to be able to give us a clearer assessment of the unmet need and improvement or impact on patients than if we let a sort of a standing panel give us their opinion across so many different potential disease indications. So that was our thinking about it and some of the considerations that went into that.
Okay, Keith, I don't know if you have a follow-up comment or question on that. Otherwise, Maria, you had your hand up and then pulled it back down again, I think. But go ahead, Keith.
If I could just make one quick follow-up. So thank you, Gil, for that.
You bet.
What I would say in response is that it's you said to me the key word, which is generalist. And my experience in review is really of basic science NIH applications mostly, but also I've sat on several postdoc fellowship panels where you get a huge diversity of different kinds of science coming in, and the real key to being able to make good decisions is having exactly what you said, having generalists in the room, so. In my view, that's the main thing that you want throughout the whole process. Having, at least in basic science, having content experts, people who are actually responsible for creating a given paradigm. Those people are biased against anything that runs against their paradigm. And so when you ask if this is in basic science terminology, addressing an unmet need, the content experts are going to say, no, we've got this covered. If somebody comes in and says, we need to be doing something in a different way, thinking about the problem in a different way. So generalist is the key. And I think finding people like that to serve on these panels and then obligating the applicants to talk about what, in this case, with clinical applications, to talk about the unmet need, to talk about improvement over standard of care, is essential. But and the generalists can then make an assessment of whether this would create a meaningful advance. So I think that there is another way to think about the points that you've raised.
Yeah. Okay. Thank you, Keith.
Yeah.
Okay, Maria, did you have a follow-up? No?
Nope, I'm good. Thank
Okay,
you.
Monica?
Sort of following up on what was just discussed, and I think the unspoken fear is that, the next breakout idea of an unmet need, impact on patients, or, one of these other things somehow didn't pass the objective criteria. So I have two questions on that, since it sounds like you might partly have this answer. You've mocked up retrospectively on the grants that have come through. Was there a sense, you said most of them would have gotten through, is there a sense that you would have lost some things that have progressed well over, the cycles or as they've developed? So you must have some information on that, and that might address people's fears on this. And then secondly, it might be something that it's the first pass on the examples, but you have some either generalist or something that just does a look over to see, in a sense, should anything be pulled out of triage? In something that was triaged by this objective criteria, was somebody just looking over that and just saying, should this be looked at again? So that's the two questions. One, what's the data from your mock looking back using this criteria? Would anything significant have been lost that actually was successful? And then two, have you thought about somebody just looking at what was triaged just as a first pass, as a maybe, 2 or 3 people that you have as a panel. It doesn't have to be as accurate. It's just a heads up.
Yeah, no, that's a great question. I think the difficulty in answering the question is that we didn't, the objective criteria are different from the scientific review criteria. So you can have, for example, a non-California organization that maybe has a great project, and we would say, yeah, it did well in grants working group review, and maybe ultimately it leads to something significant. But these objective criteria are really prioritizing the things that we think we should fund, or the kinds of projects that we think should move forward over others, not based necessarily on the scientific elements, but on a more programmatic level. And so I think it's difficult to know whether ultimately it's going to not select a project that might be successful down the line. I mean, we don't have the data for that, because that would be a long-term question. But on the other hand, when we compared, what got selected to say what got ultimately recommended, it aligned decently well, not in all cases, but a lot of what was recommended by the grants working group ultimately are things that we saw move forward. So it suggested that it wasn't doing anything harmful necessarily, across the board, if you look at, the total number. But, if you look at it from the perspective of one given application, in some cases they move forward, and others they didn't. But I think overall it didn't really do anything that we would consider to be selecting against the things that we would want.
Thank you.
Other questions? Comments? Scanning through here, I don't see any other questions at all. Okay.
Mark,
Let me go ahead, JC.
Yeah, thank you. I just wanted to make a couple of comments here. One was wanted to reiterate the points made about the excellence of the presentations by Jen and Gil. Putting the budget together is a very complex effort that requires a lot of cooperation by members of the scientific team across CIRM, and to be able to pull it all together in a fashion that results in the presentation today is a real skill. And I just wanted to thank Jen and everybody who's involved in that for all the effort that went into that. With respect to Gil's program, a number of you have noted how good a job was done on that. That too took a great deal of time and effort by Gil and the review team, members of the leadership team, and it's, as I made the comment in the past, we asked at the beginning of the year a lot of the team to put together a number of very transformative changes to what CIRM is doing. Flow control was the first domino to hit here as it's coming to the board. More will follow, will converge into a unified crescendo in September. But I wanted to congratulate Gil and the team and everybody who's worked on this for a great effort here. This is the first time we've done this in 20 years, and it's a big deal. So I want the board to know that. Lastly, I just wanted to make a point that sort of ties Jen's budget and Gil's flow control presentation together. So you'll recall that Jen was asked for the sense of the committee with respect to a $410 million 6-month budget. And you'll notice that that's quite a significant number for 6 months. But the point I want to make is, first of all, to reiterate that there were $148 million included in that 410 that were rolled over from last year. So if you took those out, the ask would have been 260 plus. But beyond that, with respect to flow control, once we bring to the board the recommendations for the strategic allocation framework in September, depending on how the board chooses to go with those, what will result in any event will be a number of changes to what we've done in the past, and the changes will require several months to implement. And as such, the budget for the second half of the fiscal year will be significantly lower than what has been asked for the first 6 months. When you sort of add the two things together, you're going to end up with a typical year's ask. And I thought that was a point that was something worth highlighting to the board, as it kind of neatly ties, again, the budget and the flow control recommendations together. So again, thank you, team. Excellent job. And back to you, Mr. Chairman.
Great. Well, thank you so much. Those are great, helpful comments here. And then currently then, Scott, if you can advise me again, do we want to provide a sense for the committee of the communications to the board? Is that the proper next step here?
That's right, Mark. I would see if there's any additional, or I should say any public comment. I think we had one perhaps earlier, and then yes, just survey the committee and see if there's any objection to moving forward with it at the board.
Okay, so with that in mind, then let me get a sense from the board, and then we can, the Science Subcommittee, and then move to the public comment question. So with that in mind, just wanted to be able to ensure that we've taken proper consideration around, the comments that have been made so far, but wanted to follow up and see if there are any objections to taking forward as a sense of the committee in providing these communications to the board, and obviously there'll be a further discussion at the board as well. Any questions or concerns? Okay, with that in mind, then I think there's opportunity for public comment, if I'm not mistaken. And I'm not sure who was first related to that.
Okay. So there are 2 hands raised for public comment. Terry first, and then Kate. Each of you will get 3 minutes each. I am keeping time. So once you hear the clock, I will mute you. So Terry.
Okay, thank you. I also want to let my appreciation be known to the committee for all the work that they did for this. And I just want to clarify something. I don't know if you can answer this or not, but I want to confirm that I heard that the deadline is right for submitting a CLIN 2 grant is now, you think it's going to be at the end of July? And the second follow-up to that is, would you know when the portal will actually open?
Yes, so yeah, our intent, assuming that we get approval by the board in June, that the first deadline would be the end of July. And our goal would be to open the portal by the beginning of July. So it gives you a short window to put an application together. We need to create new applications for this, but that is our estimate at the moment.
Okay, thank you. That's all for me.
Okay, all right. Thank you so much, Terry. All right, Kate, you have the floor.
Hi, thanks. This is Kate Maziuk. I'm a project scientist at UCLA. I wanted to make a comment about the objective criteria scoring system, and specifically about the criteria that prioritizes applications with a greater percentage of California spend. So I know for our program, and this probably applies to many of the other programs at these later stages, a huge percentage of the grant budget is spent on cell and potentially virus manufacturing. And often these facilities that make these products are very specialized and located outside of California. So I just worry that this criteria could potentially incentivize applicants to pick California-based organizations that may not necessarily be the best choice for their program. It could potentially compromise the success of the program by not being able to use well-vetted manufacturing facilities outside of California that have a good track record. That's my comment.
Would you
Okay.
like me to respond, Mark?
Please, please.
So thank you for that comment. It is something that we considered. I included it in the slide as one of the ideas that we initially had for objective criteria. But you know, you presented one of the potential reasons why we don't want to consider that, and we have thought of actually a couple of others. And so we in the subsequent slide, on slide 15, you may notice that I didn't include it as one of the ones we recommended. It was one of the things we considered, but there are a lot of elements that may make it difficult for us to actually truly assess objectively, and something that is subject to changing over time. So we chose not to include it as one of the ones we recommended.
Thank you for the response.
Okay, great. Okay, with that, I believe that concludes the meeting for today, unless there are other questions or comments that the CIRM staff would like to bring up. Okay, with that, we can be adjourned. So thank you so much for your participation. Massive amount of work here going on by the CIRM team, and I'm in awe of what they're able to get accomplished. So thanks, guys.
Thanks, everyone. Appreciate it.
Thank you.